Good morning, everybody. It's really a pleasure to introduce Dr. Erwin Bottinger to give grand rounds. We've developed a really interesting relationship with his program in the Department of Family Medicine here at Mount Sinai. My name is Red Schiller. I'm Vice Chair of the Department at Mount Sinai and Chief Medical Officer at the Institute. And welcome to our folks here at Hatch and also our remote colleagues. I'll remind you, we do have a sort of a go-to meeting set up so that there's a remote group, and should there be questions from the audience, we will remember to repeat them. Dr. Bottinger was born in Germany, where he received his medical degree from the University of Erlangen-Nuremberg and trained in internal medicine and nephrology in the States, including his nephrology fellowship at Mass General. Did additional research at the National Cancer Institute and joined the faculty at Einstein. In 2004, he came to Mount Sinai and currently holds the endowed chair as the Irene and Dr. Arthur Fishberg Professor of Medicine. He is currently the inaugural director of the Charles Bromford Institute for Personalized Medicine in 2007. His research is focused on early pathomechanisms and biomarkers of diabetic nephropathy and non-diabetic kidney diseases. His research laboratory has continuously been funded by our own research grants from the National Institutes of Health since 1998. He's currently the principal investigator for Mount Sinai's BioMe hospital-based biobank, and this includes a chronic kidney disease biomarker consortium in electronic medical records and a genomics network, or eMERGE. And very briefly, so we can get started, what's great about this collaboration is, typically those of us in primary care, and especially those of us who work in underserved communities, are often late to the dance when it comes to advances in medical research. And this collaboration has actually allowed us to be at the forefront, both in terms of identifying a very common problem that we're faced with in our communities of chronic kidney disease with people with diabetes, but developing the tools to identify these people and begin to target this, in addition to using not only the tools of electronic health record, but our ability to outreach people and work with them, and then having collaborators who have the power of this emerging science of personalized medicine is really just a unique opportunity. Welcome. Thank you very much.
Well, thank you for the very kind and nice introduction, and boy, are we off to a good start this morning, aren't we? I've been actually looking for job opportunities in Nebraska, but they're hard to find. And New York is fun too, as we all know. All right, but this is my second day in a row, as Diane Hauser will confirm, that I was, victimized by the traffic conditions. And I don't know why they took so many lanes away from the avenues. When I walk, I like it. When I drive, I don't like it. Let's get right to the subject. I have some time to make up here. Personalized medicine, right? I mean, it's hard to escape the term in the public media, on social media. It is out there. And what it really embraces in its ultimate concept is that basically at birth of an individual, we are now seeing the opportunity that, at least as far as the genetic susceptibility, the heritable part that contributes to disease, that we can actually measure at birth. And this is based on the positions in the human genome that differ between individuals, and with sequencing and genotyping, we can measure this variation very cost-effectively and precisely, and we can have this information feed into the overall risk assessment of a patient or an individual to develop a disease or to respond to a treatment or to have a severe adverse outcome in response to a certain medication. So those are the kind of things that we are approaching increasingly from a predictive angle. And when you look at this cover from a Time magazine of a few years back, these are all diseases that we're dealing with, common diseases, not so common diseases, some devastating diseases, some diseases that are debilitating over a long period of time as chronic degenerative diseases. As you know, in primary care, family history is a great predictor of risk, and to the extent that family history captures environmental exposures, lifestyles, it also captures the genetic susceptibility that's passed on from generation to generation, and we're making great progress, without going into the details here, in uncovering which specific markers in the genome of an individual are related to the heritable part of the risk to develop these diseases. And ultimately, we want to build this into a model where we can predict the risk much more precisely than what we can do to date, where most of our risk estimates are based on population-based averages and studies thereof. So that's the difference. And so that then hopefully will lead to a much more precise targeting of preventive interventions than what we're able to do today. Okay, so this is all possible now through technology, and the technology in two areas in particular. One, the development of sequencing platforms that allow us to really sequence the entire genome of an individual now for about $1,000. And so that information generated is a once for lifetime generation. It's not like a conventional clinical laboratory test that changes with variation and with disease conditions. The genome is static. We are born with it and we die with it. And so based on that, one examination of the genome through sequencing can be with a person's health record for a lifetime. Okay, the other part that's important is to understand that it's not only about sequencing a genome, it is also about what are we doing with that information. And the challenges are quite profound because the computational demands in processing sequencing data are formidable. And so we needed to have supercomputer and large storage capabilities. And fortunately, the prices for those computational resources has also come down dramatically. So now from a financial point of view, or from an economic point of view, a clinical test of whole genome sequencing is not extraordinary. It's not out there. It's not more than some of the more complex clinical tests, imaging, etc., that we have currently in clinical care. Whereas 10 years ago, it used to be hundreds of millions for a whole genome to be sequenced. So then the prediction would be that in addition to our well-known and trusted, or not so trusted acumen of diagnostic tools, such as the stethoscope and others, EKG and others, we will have sequence as a diagnostic tool. Here you have a sequence read from a sequencer with the letters under each peak. So it looks a little bit like an EKG. Just imagine that in the future, sequence information of your patient is part of your diagnostic repertoire. Okay, so, but what about today? After this tour to a future vision of personalized medicine, I want to impress on you that as of today, there are genetic tests that we can apply in clinical care that are of demonstrable utility. And this is in particular in the area of using genetics to predict the effectiveness of a medication that we're about to prescribe, or the risk for a very severe adverse reaction to that medication. So this is pharmacogenetics. There's diagnostic clinical sequencing at many centers now, where in particular in children with devastating syndromic manifestations that go through a diagnostic odyssey of established tests that do not provide a diagnosis. Many of those cases are now referred to a diagnostic sequencing team, where a team convenes and interrogates the whole genome sequence of such a poor patient, poor in terms of the condition that's affecting them, and through team studying and analysis of the sequence, one in 30% of cases, those are the early reports out of the large sequencing centers, can come up with a molecular diagnosis. and that can lead to drugs targeting that syndrome, and in particular pharmaceutical industry is very interested because they have orphan drugs, and for many of these targets, these drugs are actually useful. So this is an area that is not so much reaching into primary care, certainly not so much reaching into your realm of clinical practice, but certainly in pediatrics, there are some important aspects to be considered in this area. And then we have disease risk prediction and prevention, and the collaboration between our institute here at Mount Sinai and the Institute for Family Health is embarking on a project that is active in this area, and we'll get to this towards the second part of the talk. You're probably familiar with the Angelina story, Angelina Jolie, and her history, family history of breast and ovarian cancers, leading to genetic testing for BRCA1, BRCA2, and indeed turned out that she had a variant that would predict high risk to develop breast and ovarian cancer. And so the ultimate preventive measure in this case was, and what Angelina Jolie chose, was mastectomy to avert the risk of developing cancer. But there are a number of others, and I want to just point out this slide that if you see cancer patients, early age with family history, there is now a spectrum of conditions where genetic testing can establish the correct diagnosis and flow into the counseling and advice for how to work with those patients, in particular familial adenomatous polyposis, and various colorectal cancer syndromes are also of consideration here. So pharmacogenetics, I think you will not be too surprised, although when I give this talk to patient groups and lay audiences, they are very surprised, but you probably will not be too surprised to see that of the large blockbuster kind of categories of medications that we are prescribing every day to many, many patients, there's a chance of about 1 in 2 that a medication may not work. And so these are the data depending on the class of drug, but this is quite concerning when you think of it, that many of our patients that are taking pills faithfully every day may not get a benefit and actually walking around untreated because they're not on a right and effective medication. So we ought to do better here. And so what I mentioned briefly in the very first slide, through genetic testing within the population that you have on the top level, where you have green, red, orange mixed, by genetic variation, we can identify those that would respond to the medication that we are prescribing, and those that would not get a benefit and therefore continue to live with risk or untreated, or those that have a very severe side effect. And utilizing the technology that has evolved in this area with genetic tests and chips that can be used for clinical diagnostic testing in this case, we now have the following scenario that when you look at the top 20 primary care prescriptions as of 2010, I got that from a primary care journal, so this apparently is the list of the top 20. Those in purple are actually those for which genetic guidance can help in making more precise prescriptions, right? So, and the list is growing, and it's, I think, unavoidable that in the near future you will have situations where the prescription of a common medication, such as lipid-lowering medications, such as simvastatin, for instance, clopidogrel, Plavix, warfarin, which is going away, but it's not gone quite yet, opiates, many others. There are genetic markers that can help you in more precise prescribing. And here are some that are implemented in a pharmacogenomics program at Mount Sinai. So here are the drugs that you have listed, and then the genes for which tests are available, and the clinical actionability is on the last column. So it affects the correct dosing using an alternative drug, for instance, in the case of Plavix, antiplatelet, where if you are predicted to be a non-responder, poor metabolizer, which is in 1 out of 4 patients. It's very, very common. One would recommend to use prasugrel, an alternative drug, and so on. So we have here at the Institute for Personalized Medicine implemented a pharmacogenetics program as one avenue for personalized medicine. And in this program, we have developed a software tool that interacts with the electronic health record. In our case, it's Epic. In your case, those of you who are working at IFH facilities, it's also Epic. And so this software can deliver genome-informed clinical decision support directly into Epic, and it incorporates the genetic information that is available for a patient. And at the time of prescribing, when the patient is in front of you in the office and you enter an order for one of those drugs that I've shown on the previous list, and if there is a genetic variant that would indicate that this patient may not respond or may need a different dose or may be at risk for adverse reaction, you will get a clinical decision support at the time of entering the order. And the clinical decision support also has a smart set of alternative recommendations. So we try to make it as workflow integrated as possible for the clinician so that you don't have to click around, leave your routine workflow from the EHR desktop. It's all presented right there together with educational materials. And for us, the key is to do this in real time at the point of care. That's very critical. So here's just a cartoon outlining this system that's called ClipMerge. And so you have your electronic health record. I don't want to go into too much detail. It's a complex system. It's interacting with Epic. It's not inside Epic. And it receives the genetic test results from the genetic testing lab. And in the context of the clinical presentation and the order that is about to be entered, it makes recommendations about precise prescribing of medications. This is what it looks like when you're in the Epic. This is a screenshot. When an order is entered, in this case, it is for Plavix, for clopidogrel. And by genetic testing, this patient actually, it turns out to be a poor metabolizer. The advice is that this patient is at risk to not getting any benefit from Plavix, and we recommend the alternative medication, in this case, prasugrel or ticagrelor. Okay, so this is just a concept of what we have implemented and what is live and happening in Mount Sinai primary care facilities, the IMA as well as the FPA. There are two large programs. One is funded by the NIH. It's called the eMERGE Pharmacogenetics Program. In this program, we are applying sequencing to 900 patients, and we are sequencing 84 genes that are the most important genes in drug metabolism and drug response for the most common drugs. And so sequencing happens when the patient enrolls in the study. The sequence data, it resides in the ClipMerge resource. And when an order by a physician for that patient subsequently is entered for any of the drugs where the sequence data is relevant, the decision support displays. And we have a similar study in this case in the IMA where we are genotyping 1,500 patients and following what the clinical decision support and what impact it has on precise prescribing and improving the outcomes for patients. Interestingly, from the sequence data, from the sequencing, we can actually ascertain for how many patients or predict for how many patients that we treat will we expect actionable genetic results. And in this case, from sequencing the first 500 patients, we know from analyzing those sequences that 3 out of 4 of those 500 patients have a genetic variant that is actionable actionable means change in the prescribing pattern, if they get clopidogrel, warfarin, or simvastatin. So that is quite substantial, and we have now extended this to the other drug gene pairs, and it turns out that 100% of patients, when you look at 10 genes, at the 10 drugs that we are commonly prescribing, 100% of patients have an actionable variant if they are receiving one of those 10 drugs. So I think in the future, and this is my prediction, this will be fair and square relevant in primary care as we use medications that are commonly prescribed. Okay, so from this detour through pharmacogenetics and what's happening today, let's move on to disease, common diseases, not so common diseases, and where are we there with regard to making genomic discoveries and also integrating the results from these discoveries into some clinical practice model and that allows us to be able to assess whether it has any meaningful impact. So here are again from the same journal you probably figured that I used before to get the top 20 prescriptions. We have the top 20 primary care diagnoses. You may or may not disagree, and it probably has some local flavor to it. And in your practice, this may not be the top 20 list. But clearly, hypertension, hyperlipidemia, diabetes, I think nobody would argue that those are on top. Osteoarthritis, pain in the joint, asthma, major depressive disorders. For those conditions, we have genetic data today that is reasonable to be introduced in a clinical care context. And what I mean by this, I'll get to it in a little bit. So, which brings me to our large biobank program. This is something that you may have heard at your facility as well, because we're working with Dr. Kalman and the team at IFH to allow us to extend biobanking to the IFH practices, to enable IFH patients to contribute the genomes from their communities into the research networks so that they're not excluded from the discoveries, but they are included in the discoveries, and therefore the discoveries should also be relevant to the patients in our communities. That's one of the major driving considerations for this. So what is it? It's an IRB-approved research program that's active at Mount Sinai since 2007, and it's fully integrated in clinical care processes. It allows discoveries, and it is, since the patients are consented, they give a blood sample from which we extract DNA and plasma, and they also consent that we can research in the electronic health record and that we can recontact them if there are findings that are relevant or critical to their health going forward. So this is the key information. We have DNA. Much of that DNA we now have sequenced or genotyped, so we have large-scale genetic data for many of the participants, and we can look in the EHR for clinical features and link those, and if there's something of great importance, we can recontact. So this is the key principle. So by now we have over 30,000 patients enrolled from Mount Sinai facilities, and they're, quite well reflecting our patient populations from the local communities by and large. Over 10,000 Hispanic Latinos, about 7,500 African ancestry individuals, and about 9,500 of European ancestry. We are adding about 400 patients a month to this resource, and so here's the breakdown. Again, this is in the graphical form. What this is linked with what was already mentioned in the introduction through an NIH grant with a large network of similar biobanks linked with electronic health records that is around the country involving 10 institutions. That's the so-called eMERGE network. And you'll hear more and more from this network because a lot of great work is done there. And the eMERGE network stands for Electronic Medical Records and Genomics. And what it now does, including our 30,000 individuals, it expands the population to over 350,000 total patients enrolled in this similar resource across the country at these 10 sites. And for 100,000 of those, we also have the genetic information, and there's a lot of powerful work going on that you'll hear about in the near future. And so again, I cannot overemphasize the importance that our patient populations have access to research studies where genetic discoveries are made. Because as you probably know, conventionally and to date, there has been a great bias in these studies towards Caucasian European ancestry study populations. out of the Scandinavian countries, European countries, etc. And so minority populations have been largely excluded from these studies. And if you don't have them included in these studies, the findings are by and large may not be relevant, right? So, and we need to actually create a pipeline where we can bring our patient populations into this research so that the findings are then applicable to our patients. And you will not be surprised that there are great population-specific differences in the relevance of genetic markers towards disease, and one of these examples will come to in the story of APOL1 and kidney disease. But through our biobank, we've brought our population, this 10,000 Hispanics and 7,500 African Americans, into these large international studies looking at most of the major common diseases. And I think that is a very powerful and very important consideration, and we're very proud, and we would love to extend this into more facilities surrounding us here in Manhattan and the Bronx, to bring people, to allow them to have access, to get them into those studies, to make the findings relevant to our populations. Again, I've said this 3 times, now stop me when I get to it a 4th time. Okay. Just an example, how, because we are linking with electronic health record, how we can actually even address complex phenotypes. If you look at here, 3,200 in some cases with coronary artery disease out of the 30,000. When we look at, okay, we want to look at those that also have hypertension, those are 3,000. And then we want to see which have high lipid levels and have a history of a myocardial infarction. We have 750, so we can very readily identify patients with a large disease burden, and in particular focus on those and see whether we can make the genomic discoveries to unravel the underlying genetic susceptibility of individuals affected with very large disease burdens. This is just one example. So another interesting aspect, and we're very excited about, that we have recently made to work here, is that we can use this for translational research. And translational research where we bring the results back directly to impact on the care of our patients enrolled in the BioMe biobank. So from the research, we can identify genetic variants, we can discover those, and if they are of particular interest, we can go back to the electronic health record and do what we call deep phenotyping, where really an expert is going to the electronic health record and reviewing for features in the record that could be explained by the genetic variant. We can recall the patient and go run additional tests, confirmatory tests, and then in the end we can return results to the patients and make a molecular diagnosis in cases where they are treated without precise underlying diagnosis. And I have an example that illustrates to you the power of this. So through the research, we identified a mutation in collagen gene, collagen 27A1, in particular in individuals from our Hispanic community with very, very short statures. I tell you, very short, right? And so we saw this association, and so then we looked at the electronic health records and of 4 individuals that were carrying this mutation. Here there are 3 listed. But our eyes popped when we saw this, that indeed, you know, it's not only a variant that we identified through association with short stature, it's also a variant that is very relevant, apparently, to their connective tissue health. So these have histories of congenital hip dysplasia, cervical cord compression, scoliosis, congenital hip dysplasia, multiple joint replacements, and so on. So this is not random. Let me tell you, I've done a lot of research. This is not random. In almost all of them we have, in all 4 of them, the 4th is not listed here yet, we have this kind of dramatic connective tissue and bone and etc., bone development, joint development problems. So we're not just curious about this, but when you look at this, 2 had actually cervical cord compression, requiring acute emergent spinal surgery to relieve the pressure, right? So wouldn't it be important if we have additional patients that we have in our system that carry this mutation, that we as providers and the patient should be aware that there's a risk that they could in the future develop cervical cord compression? I think that would be important to know. And we are at a stage now where we can make these kind of discoveries that directly translate to how we may manage patients going forward. So screen for cervical cord compression. So, and in one case there was a misdiagnosis. That individual was treated with 2 heavy immunosuppressive agents for polyarticular juvenile rheumatoid arthritis. And that was not the right diagnosis. So with the genetic information, we could actually clarify and provide a correct diagnosis and spare somebody who certainly does not need heavy immunosuppression from this regimen, right? So I think this is sort of the power that's in a resource like the BioMe Biobank, where we can work with the patients going back and forth and see whether we can come up with molecular diagnoses that have an impact on how we manage the patients. So this is again just the summary of what I've told you, and I want to move on now to a story that we are very proud of, we all can be proud of, including Diane, who is sitting here, Dr. Kelman and the team at IFH, and our team here at Mount Sinai, and we just yesterday had a fantastic meeting with about 30 people that are involved in a study that is about to happen. And it's the so-called GUARD study. It stands for genetic testing to understand and address renal disease disparities. And here we're getting into the context of the large item that I listed on my very first slide of common disease risk prediction using genetic markers. Similar, like, you know, in concept, you would use cholesterol level as a marker for the risk of coronary artery disease. Just extend that concept and think of genetic markers as, you know, a predictor of the risk of, in this case, particularly chronic kidney disease. Again, this study is funded by the National Human Genome Research Institute, and we are about to embark enrolling patients at a number of sites here at Mount Sinai, as well as the Institute for Family Health. And so give you a little bit of background. Why do we think this is important and has potential utility in the way we manage patients, in particular African American patients with high blood pressure? Because, as you know, African American patients are particularly affected, have really very excessive disease burden from chronic kidney disease. And so here are the numbers. The most important one is that African Americans are 5 times more likely to progress to end-stage renal disease when they have kidney disease, in particular associated with high blood pressure. And through discoveries by a number of groups applying genomic technologies to understanding kidney disease, risk variants, mutations were identified in a gene called apolipoprotein 1, L1. ApoL1 for short. And we found that these variants are very strongly associated with the risk to develop kidney failure in African Americans. And so when one has 2 risk copies, so homozygous or heterozygous for the 2 risk copies of this gene, the risk to develop end-stage renal disease is 5-fold higher. And when we extrapolate this then with lifetime numbers, the average risk to develop end-stage renal disease in the population is 2 to 3%, whereas if individuals have 2 copies of the risk variant, it jumps up to 10 to 12%. So it's a very substantial increase in the risk to develop kidney failure associated with hypertension. Now, why is this in African Americans? We have a video in the end that will explain it. Carriers of 1 copy of the mutation, they were in Africa protected from sleeping sickness. It's the similar paradigm to sickle cell and malaria. This was in one environment, a protective mutation has been selected for in the genomes in that context. That's why these variants are so common in the African American population here. And they're much, much less common in the European population. They're less than 0.01%, whereas in the African Americans, through this selection in Africa as a survival advantage, we have 14%, 1 out of 7 African Americans in our community has 2 risk copies. So it's very prevalent, and it's not something rare. So what we have proposed and what was received by study sections and colleagues and advisory groups with great enthusiasm is that we would focus on African American patients with high blood pressure. We would invite them to consent to participate in the study. They would be randomized to genetic testing versus not for ApoL1. Most of them, 6 out of 7 would be receiving genetic testing immediately, 1 out of 7 at the end of the study in a control group. The test results could be either positive or negative. If there are 2 copies, they are ApoL1 positive. They have a high risk, as I said, 5-fold increased risk for developing kidney disease and kidney failure. And if they are negative, their risk is like population average. Okay, and what we would like to find out is whether sharing this information through the system that I described before, the software that can display clinical decision support when you see that kind of patient enrolled in the study in your practice. Through EPIC, there's going to be a best practice alert advising you that in this study, based on genetic testing, this patient in front of you is enrolled in the study and has tested positive and has an increased risk for kidney failure. And you also have right away the last 3 blood pressure recorded for that patient, so you can reflect on increased risk to develop a complication of high blood pressure, and you have the last 3 blood pressure readings and whether or not you need to do something to improve blood pressure control for that patient. So what are the potential impacts, right? So if you have a positive result, that's what I just explained to you, one would want to presumably pay particularly attention to blood pressure control. Also, because this is about risk for kidney disease, one might want to think about, do I have urine albumin, urine protein tests on record? Have they been negative recently? Do I need to order some to assess whether or not kidney disease is actually present in this individual? If the negative results, you just go with the no change in care, how you would care for the patient, the way you are usually practicing in your practice. So what it provides, what it offers to providers is a chance to become familiar with a common disease genomic medicine paradigm. Again, 1 out of 7 of patients enrolling in the study will be positive, will have positive results, and hypertension is very common, and so you will have exposure to this genomic medicine paradigm at the forefront in primary care. And this is, to my knowledge, the only study like this currently that is rolling out in a primary care context. Okay. For patients, if the test results are positive, will it motivate them to be more compliant with their prescription, have weight loss, other lifestyle modification changes? So we don't know that, but this is part of what we want to find out through this study. If negative would be normal risk, could provide reassurance to them. And so we have so far tested and returned results to 27 patients. And the response was that they feel relieved, that they know they don't have increased risk. If they do have positive test results, then they feel positive about it in the sense knowledge is power. Those are the phrases that we were told by the response from the patients that received results. Those are not my phrases. So knowledge is power. I will take better care of myself. I will make sure that I'm compliant and that my blood pressure stays controlled, and so on. So the pilot findings from the patient's response is very encouraging. There was no decision regret. And so as this project emerged, and the American Association of Medical Colleges became aware of this, and they invited us actually to produce a video about our project. And that video is featured on the AAMC website, where there's a program on health equity research as one of 7 other projects that are focusing on health equity. Our project and your project is featured there as well. And I have the privilege to play this video for you. Hello, everybody. My name is Erwin Bottinger. I'm a professor of medicine at the Icahn School of Medicine at Mount Sinai. Our elite team of researchers and doctors is studying how a person's genetic makeup can inform us to deliver the right treatment to the right patient at the right time. We have the potential to change the practice of medicine by preventing disease proactively rather than treating symptoms reactively.
Some findings by the world-class team of researchers at the Charles Bronfman Institute for Personalized Medicine are already implemented in a particular patient group. Many studies have shown that high blood pressure and its major complications, such as kidney disease, are up to 7 times higher and have higher morbidity and mortality in African Americans than in any other population. Regular blood pressure control is particularly important in African Americans with hypertension to reduce the bad outcomes associated with kidney disease in this population. We know that many non-biological factors contribute to disparities in health and health care, but biological factors are also playing a role. A substantial part of the biological disparities in kidney disease in African Americans can be explained by variants in a single gene called APOL1. This variant protected people on the African continent against sleeping sickness. Now, with the help of APOL1, genetic testing applied to people of African ancestry with high blood pressure, we can identify individuals with the highest risk of developing kidney failure. In a clinical trial funded by the National Human Genome Research Institute, we will examine whether and how sharing of APOL1 gene information with hypertensive Black patients and their primary care providers in routine clinical care can improve kidney disease prevention. This is one of the first studies ever conducted to impart genetic information that can help address a common chronic disease and a disease characterized by profound health disparities. There will be many more genetic discoveries we will need to share with frontline clinicians and patients in diverse settings. Co-principal investigator Carol Horowitz and our study team lead regular meetings with local clinical and community leaders to make sure local people from the predominantly Black neighborhoods of Harlem and the Bronx have a chance to benefit and will actually take advantage of this new discovery. Together, we are creating educational and clinical tools to share this information and disseminating these tools to see if we can improve clinical practice and patient outcomes in our shared goal of eliminating racial disparities in kidney disease. We have already begun to test patients for APOL1 and return results to patients. The response has been overwhelmingly positive.
I'm really glad that I was involved in the testing for my kidneys, only because I had no idea before then that it coincided with my high blood pressure. Now that I know, I'll be more aware of my body and make sure that I keep on top of my exams and my health. And hopefully I could pass it on to my community, the people in my neighborhood of African descent.
Dr. Neil Kalman is a board-certified family physician who has practiced in the Bronx and Manhattan for more than 30 years.
It's exciting that our patients, often the last to benefit from new breakthroughs in medicine, will be among the first to get this new information. Armed with this genetic information, African Americans who carry this gene variant will be able to focus on the management of their high blood pressure with their primary care providers helping to prevent the onset of the devastating effects of kidney failure.
With the video, I want to stop. We have a few minutes for questions. If you're interested, I'm very happy to answer any questions you may have. I apologize for the delay. There's a large number of people involved in all these programs. I'm particularly excited going forward to work with the Institute for Family Health and Diane and the whole team on these projects. I think it's exciting, and I think it might really lead to improved care for our patients, and certainly also in bringing our patients into large research efforts to find out how genetics can be used to improve care for our patients. So thank you very much.
Thank you for your presentation. I saw on one of the slides that one of the exclusion criteria diabetes. You're not tested as in diabetic patients. Wouldn't that exclude subpopulation?
Yes, that is correct. And the reason for this is what the scientific literature suggests, that this variance does not, at this point at least, as far as we understand it, increase the risk for diabetic kidney disease or for progression of diabetic kidney disease. So it seems to be, and we don't understand the underlying biology of that yet, but it seems to be in particularly related to hemodynamic changes and vascular alterations associated with high blood pressure. So that's why diabetes is an exclusion criteria, because we don't have any scientific evidence to support applying it to diabetic patients.
I'm just curious about the clinical usefulness of this. Suppose I have a patient that comes in, which I have frequently, who has a problem with the statins. Now, my experience has been they have a problem with one statin, they're going to have problems with all the statins. What can you run me through the clinical usefulness? Suppose I call you up, I say I got a patient that's, I'm curious, can you run the tests and can you make recommendations to me for that kind of a patient?
Yes, so that's a very good question, and it relates to two issues. One is for you to recognize, should I order a test to find out something, and then subsequent visit, this has an impact potentially on how I manage the patient. So in other words, when is the test result available? And the second one is, so what is the actionability? I mean, is there compelling evidence that it makes a difference? So to the first part, for all these studies, the testing is preemptively. So it's part of the patient consenting to be in the study. And only when it's appropriate for the provider to see a test result, that is when you specifically prescribe the medication for which the result is relevant, will you get a best practice alert, right? And so that takes away the notion that you have to order the test first and then wait, and this is a lot of extra effort to get the results into clinical practice. We're doing this because we anticipate that as sequencing is getting cheaper and cheaper, there will be, for a good number of patients, these results will be available and will be part of their health record, right? So that's the concept of preemptive. But certainly for a good number of scenarios, we would still need to educate providers whether or not a test should be ordered, right? To the main core of the question about actionability. So with the statins, that evidence is actually quite strong, and it is specific to simvastatin that variants in a certain gene, slow CB1, will actually increase the likelihood of myopathy, and that is the context there. And so this has been found that people with those variants at a standard dose of simvastatin are at much higher risk to develop myopathy. So the actionability for simvastatin and carriers of those variants, which is not common, those are not common variants, right? But if it occurs, the actionability would be either to use one of the other statins to eliminate or reduce the risk for myopathy, or to have a low-dose simvastatin. So, and that is, that context, that connection has been very well established. So, and this is actually part of national guidelines from the Clinical Pharmacogenetic Implementation Consortium, where there's a large group of experts in this area, and they're very conservative in making guidelines and recommendations about which findings are actually supported sufficiently enough to justify actionability. This is for simvastatin, for instance. For clopidogrel, another example, the evidence is also very strong, and we find that 1 out of 4 patients that is receiving clopidogrel is a poor metabolizer and will not get a benefit from clopidogrel. And that can be actually life-saving if we make the right choice for these patients, because as you know, if there's no antiplatelet activity in these patients, they are at increased risk, particularly post-stent, post-percutaneous coronary intervention, that there is a thrombotic event or some other bad outcome, stroke and MI. So this is 1 out of 4 patients that is prescribed clopidogrel is not responding to clopidogrel. So those are pretty compelling scenarios. Whether or not they are very common and prevalent in your practice, I cannot say. That is dependent on the type of practice that you have and the type of patients that you see.
I think we're after 9 and people are sort of heading back to clinic now. One thing that I did want to just make sure you're aware of, I think some of you sat in on the session at Harlem where the APOL study was introduced. In the coming months, you're going to see recruiters both at Harlem at 16th Street, and they're going to be at Stevenson and Walton. Those are the 4 sites selected for that study. And in addition to being participants in the APOL study, those same patients who are recruited are going to have an opportunity to enroll in the biobank if they choose to do that. So these are issues that are going to be very relevant to you as you see your patients, because all who meet the criteria will be recruited, and for those who enroll and happen to be in your panel, you're going to be seeing alerts and may get questions from your patients. So we just want to make sure that you're aware of that.
Just, excuse me, Erwin, thank you. Just one last closing comment. I was struck by the slide that had the stethoscope with sequencing data. And I'm reminded, those of us in primary care, we probably focused on genetics simply because it was something that we were tested on and really didn't think that there would be clinical utility in sort of understanding this. But when you think about the fact that there's molecular diagnoses now, I'm sort of mindful of the development of microbiology and that there was an invisible world that we couldn't see that was causing populations of people to get sick. And there was an emerging technology that allowed you to understand why people got sick and what to do about it. This is sort of what this feels like. We're sort of on the verge of a whole new science that allows us to target people in terms of prevention interventions, but also treatment interventions. And it's amazing that we have this collaboration. Thank you, Erwin, very much for coming.
Appreciate it. My pleasure.